in mandible, there is no straight implant. You do not put a straight implant. An implant will always be at a buccolingual angle because the implant has to go and hit the palatal cusp on the top. If I am putting an implant in the maxilla, it should come down and hit the buccal cusp of the mandible. So there are no straight implants. We die to get straight implants, while operating. The only aim is to put a straight implant, which is the wrong aim. You do not have to put a straight implant. The implant has to bear load, right? For that, it has to be at a unidirectional angle coming from the opposing tooth of occlusion. So this is where you start checking occlusion with your paralleling pens or pilot drill. Once I am okay with this, this will be my final line of placement of an implant. Right? We know about all these differences between implant and a tooth. Can we do this? Can we do it or we cannot do it? Joining teeth to implants. If a patient has 6 and 7 missing, I can place an implant on 7, I can do a crown preparation on 5 and I can give a 5, 6, 7 bridge. Can I do that? There is something which is called as TISP, tooth implant supported prosthesis. What is that then? TISP prosthesis, tooth implant supported. You can do a tooth implant supported, but only for areas which are non-load bearing, not for the load bearing areas. Why? Because whenever you have to do something like this, joining an implant and a bridge, you have to make sure that they stay in harmony. You cannot give a lot of space to one and less space to the other. That is why you are not supposed to join teeth and implants in a load bearing. What do I see in a single posterior crown? This is what exactly is required in a single posterior crown. MIP, no implant contact on light bite. What is meant by light bite? When I ask the patient to just touch the teeth. Just touch your teeth. When the patient is just touching the teeth, the implant crown should not come in contact. But when the patient is biting heavily, that time the implant crown should come in contact, but the intensity of color should be less. That is light bite and heavy bite concept. No contact in lateral, no contact in protrusion. Right, so I am going to show you a small video here. Right, if you want to record, it is not my intellectual property, right? So you can record it. This is a 20 step video from which paper to be used and how to do it step by step. So if you want, you can take out your phones and record this video. Everything is there step by step. So while recording, you should also see the video. This is all happening pre-prosthetic. step-by-step procedure of how to use which paper, where to use that paper, and where to end occlusion. So to end the occlusal settlement, you need a 200 microns paper, which is horseshoe. You put it, ask the patient to do a chewing pathway. When the patient does this chewing pathway, you remove everything from the non-functional. That is your final step when you send this patient off. I'll just take a minute. So when I'm doing a full mouth occlusion, right? When I'm dealing with a full mouth occlusion. Full mouth occlusion, do I give a canine guided or a group function? In full mouth implant. Group function, right? So this patient had this prosthesis, done by one of our course participants, and this patient was wearing this for around 2 months. But he was not very happy. He used to keep saying that, there is some sound that comes, he's not able to chew well. So our friend used to do all this adjustment, but it was still not finally very satisfactory. So when you see this at the outset, it looks to be okay, it's not bad. The lower anteriors were natural crowns, and in the posteriors they had implants supported restoration. But when I check the excursion, is it correct, this marking, or is it wrong? So I have contacts here when the patient is doing lateral excursion. I have contact only on one premolar, right? Which is wrong. I should have at least 3-4 teeth for good function. I go ahead and check the other side. Other side also looks the same. So now we understand where the problem is lying, right? Then I ask the patient to do a protrusive. What do I see in this protrusive? What is coming in contact? Only one central incisor. Will this prosthesis fail? For sure, 100% this prosthesis is going to fail. This will not fail only if the patient is only on liquid diets. Otherwise, this prosthesis is positively going to fail. Then we go ahead and I check the centric for this patient. I put a paper, I ask the patient to tap. You see how beautifully he's tapping. He has been doing it for 2 months now. So even before I put a paper, he starts doing this movement. Right? He's so well trained. But I can see that there are all non-functional marks only on 3-4 teeth, which should ideally be on all the teeth. It is implant FMIR, implant full mouth implant restoration, which means you cannot leave anteriors out of load. Every implant is same, whether it is posterior or anterior, all of them should have contacts, right? So I keep on reducing, again take those centric marks. If you do not have a U-shaped paper, you can use strips on both the side, take markings, take contacts, again centric contacts, keep doing it. We can see slight improvement, we do not have all eye points. This is how you put Vaseline on recording, before recording your eye points. Now when I put the paper for a chewing pathway, I put this in the patient's mouth, ask them to give a chewing pathway. One of the final steps to settle occlusion here. When he gives me a chewing pathway, we'll see what kind of markings he has to give us. And whatever markings are present on the non-functional, we are going to remove it. Do you see markings on non-functional? In the maxilla also we have a few markings, mandible also we have a few, and now I have reduced them all. This is where I send this patient, in centric. Now let me see what happens in the protrusive. When I am asking the patient to do a protrusive, can you also see a premolar coming in contact? Should it come in contact? In protrusive? No. So what we are going to do is we are going to reduce it. Now is it correct? Automatically I have not touched the anteriors. I have just balanced my centric. I have just balanced the protrusive. Do you see here that now the protrusive looks to be better? If not good, it is at least better than what it was. This is after correction. Now when I ask the patient to give me a protrusive, you can see that there is no posterior in contact. A lot of times you can see situations like this in full mouth rehabs or complete dentures, occlusal scan. Commonly in full mouth implant rehab. So when you see this kind of a situation, to correct it becomes a big problem. Patient will never like this smile. Now to correct this, either I need to add on one side or I need to reduce on the other. Whatever I do, this is how the prosthesis is going to be. Can you see the size of prosthesis for the lower arch? On the left side, huge. That's a fixed prosthesis. It is going to give a lot of load. What was the reason for that? The reason was my implant placement. Right? That precisely was the reason. What will help us if I want to correct this situation? To do a guided workflow. Right? When you do a guided workflow, we will not go with the entire surgery, but I will just show you how the guided workflow will give you the end result. That is the same case when we do it in a guided way. No cantilevers, absolutely. Another similar situation, no cantilevers. So guided or digital implant dentistry will help you in occlusion as well, because our implant positioning will be correct. Now just to conclude, another 3 or 4 slides, what am I basically trying to tell you? Use Vaseline on articulating papers always. Rapid taps will give you best and precise tapping marks. Position of the patient is very, very important. Always air dry. Do not depend on anything else. Air dry the teeth. Blue use for centric, red for eccentric. Pathway to be checked always when the patient is sitting at 90 degrees. Upright position always. Maximum adjustments in BISC trial. Do not skip this step, right? So that your final glazed porcelain, you don't have to touch them. Where to use what for a single crown? 40 micron for checking the deflective contact. Light bite, hard bite, and pathway check with 200 microns. These are the steps you need to do in for a single posterior implant restoration. Very, very important. If the patient is saying it is high, it means it is high. The patient is not there to trouble you. Right? There is something which we are missing because our tools are not perfect. Right? But if the patient is giving you a feedback it is high, you cannot tell them, "Mujhe to paper mein dikh nahi raha hai, I cannot see anything on the papers, and what should I do?" You cannot say that. If it is high, it is high. Maybe it is proximally tight. Maybe it is affecting the periodontium of the adjacent teeth. Maybe there is a small marginal ridge which is coming in contact. And also let me tell you that these patients, when you keep doing these repeated movements, are they going to give the same intensity of movement every time? Even we do not bite with the same intensity, right? So it is a very qualitative process. Every time it keeps on changing. That is why you need to keep following it up as well. This is how we do the follow-ups for all our implant cases. Very, very important. If my patient is attending all of this, I will give them a complete guarantee. The day they miss an appointment, it is mentioned in the consent that if you miss an appointment, 5-10 days plus minus is okay. If you miss an appointment, all warranties and guarantees will lapse. That's it. If you are not in Delhi, you are in Chennai, go to a dentist and show them in Chennai. Get those records done. Pay them for that reason. So which articulating paper to be used where? I will give you a very small outline of that, although it is a very long subject to be discussed. RT spot to be used for proximal contacts and intaglio surfaces. 40 microns for crown, bridge, implants, BISC trial, natural dentition. Chewing pathway 200 microns, 100 microns for glazed porcelain, 8 to 12 microns shim stock for final finishing, and shim stocks for checking the interdustation. Right, so what we need to understand is that occlusion starts before the restoration. When does it end? You have to keep following up, keep doing that step again and again. So that is majorly what we had to talk about today, and thank you.